What are the indications for sentinel lymph node biopsy? Any patient with early breast cancer, which is clinically node N0. So whenever we see clinically N0, we always use ultrasound modality as well as palpation. So ultrasound axilla done by a dedicated sonologist is a prerequisite to doing sentinel lymph node biopsy. If you have any abdominal nodes, you have to FNA them first, ultrasound guided FNA. If they are negative, only then we go ahead with the sentinel lymph node biopsy. And it can be done upfront and also post neoadjuvant chemo. So these are the indications for sentinel lymph node biopsy. So I have to give credit to my teacher, Dr. Paul MJ, for providing me this video. He is senior endocrine surgeon at CMC Bangalore.
Ma'am.
So I will be presenting in mastectomy as well as in breast conservation surgery. This is a patient which has got a tumor in the upper quadrant. Now when we give the methylene blue injection, we have to give So the methylene blue injection, there are various ways you can give. So we are using peri-regular infiltration of the blue dye. Around 0.5 cc is being infiltrated at various positions. You can use either 2 positions, 3 or 4 positions, peri-areolar. So basically we are targeting the subareolar plexus, the lymphatic plexus. And as you can see, sir is demonstrating that only a total of 1 ml dye has been infiltrated, peri-areolar. Other people may sometimes use subcutaneous region or peri-lesional infiltration of the dye, but it has been noticed that wherever you put the dye doesn't really matter. So we use the peri-areolar. And thereafter we have to give a gentle breast massage for 8 to 10 minutes minimum. This will ensure the dye goes into the lymphatic. I hope you can make out there is a lymphatic which is being traced, the blue colored lymphatic, and the plane it is found is just below the subcutaneous tissue. We gently dissect the blue lymphatic all the way to the axillary lymph node. And as you can see here, because this is a mastectomy specimen, we have already entered level 1. But still we are not dissecting the level 1 lymph nodes completely. Instead, we are targeting directly the blue node. And once you find that blue lymphatic leading to the node, the dissection becomes very simple. As you can see, Dr. Paul is also palpating the node again. So when we take the sentinel lymph nodes, we take blue, palpable and hot if you are using the radiocodal dye. So minimum of 4, at least 4 lymph nodes should be taken, minimum is 2. If you take 4 sentinel lymph nodes, the sensitivity and specificity will be high, and once you find a negative sentinel lymph node, you can leave the axilla as such. So as you can see, this node is quite stuck. So he has dissected the node out, and you can see the node with the perinodal tissue has been dissected. Because we need to get an idea of if is there any perinodal infiltration. So as you can see, sir, for demonstration purpose, he is dissecting the node, and you will see it's a beautiful kidney-shaped lymph node, and then we will cut it open and see if the dye is there inside. So what happens is, in a normal lymph node, the afferent lymphatics come through the cortex, and the efferent goes through the hilum. So the blue dye is expected to be there in the cortex of the lymph node. So let's cut and see where the blue dye is reached. Please notice this whole lymph node has turned blue. I'll tell you about that significance in the next case, in the next node. So you can see it's a beautiful kidney-shaped lymph node, and you can see the presence of blue dye in this. So when we cut the lymph node open, we expect to see cortex and hilum. As you can see beautifully demonstrated here, the blue dye is throughout the cortex and also gone into the hilum. You can see the cortex separately and hilum separately. So this is that particular lymph node here with the blue dye demonstrated nicely in this photo. After this, axilla was explored further to look for any other blue or palpable enlarged lymph nodes. As you can appreciate, we are still in the lower axilla. We are not doing a proper axillary lymph node dissection. And you can see here with the use of cautery, we are just going into the peri-lymphnodal plane and dissecting the node along with the perinodal tissue. And we can see here this is again a big node, in fact bigger than the previous lymph node which was dissected. And you can see the presence of blue dye in this. I hope it's so after the lymph node is taken out, we will again demonstrate the presence of blue dye. So now if you have the facility of frozen section with you, you can send all the 4 lymph nodes for a frozen section and wait. If the nodes are negative, then you are done with the surgery. If nodes are positive, then depending on what criteria you are using, either you dissect the axilla or you can leave that for axillary radiation. So here you can see we are palpating the lymph node because they don't use frozen section at CMC Vellore. So they palpate the lymph node, they dissect the whole lymph node off table dissection, and he's demonstrating here this is a large node. And blue dye is present only in this part of the cortex. You can appreciate here. But in the lower part of the lymph node, it is gritty and it feels different and it is different. So he is suspecting presence of metastasis in this aspect of the lymph node. You can also do a imprint cytology if you don't have a facility of frozen section. But still frozen section is better. This is a large node. It has been opened up and one part of it looks abnormal, this part. So he is planning to take that separately and send it for biopsy just to ensure that is. So this is the sentinel lymph node specimen. You can see 1, 2, 3 and 4 blue nodes. So let's come to the second case. Here demonstrated a sentinel lymph node in a breast conservation surgery. So obviously there will be 2 separate incisions. So as you can see, the patient is not painted and draped. Usually because we have to give the gentle breast massage for 8 to 10 minutes. So we can utilize that time to scrub and wear the gown. So again he is infiltrating 0.5 cc at one area and 0.5 cc at another area of perineal. Please ensure that you don't give it subcuticular because then there are chances of skin necrosis. And a lot of time question is asked regarding tattooing, but we don't see it as a major problem. The problem with giving the dye very regional is then wide local excision part becomes very tough. Everything is blue. We have done the wide local excision and you can see the axillary incision for sentinel lymph node. In this picture, you can see the clavipectoral fascia is partially open, and you can see a blue lymphatic here. This one just piercing the clavipectoral fascia. So now, once we have found that blue lymphatic, we gently dissect around it and we open the clavipectoral fascia even more. You can see here how focused our dissection in the axilla is to minimize the mobility of lymphedema and nerve injury and pain. It will be better seen once we dissect to the lymph node. As you can see here, this lymphatic will be dissected laterally into the axilla. We just open the tissues, just like we used to do any axillary or vein dissection along the artery or along the vein. Similarly, dissect along the lymphatic. Suddenly we see that the blue node is popping out. So now we reach the node, so we are dissecting around the node. So now you see the node has popped out and it's completely blue. So the whole lymph node has turned blue. So probably if we go clinically, probably it will not have any macrometastasis. taking out one lymph node is not enough. So the axilla with perimodal tissue you can take out. So by palpation and inspection, all the sentinel lymph nodes in the lower axilla were removed. So this is the breast conservation and the sentinel lymph node specimen for this patient. Thereafter, we usually close the axilla